Okay, perfect. So yeah, really great to see so many people join this morning. Say these have been some of the most enjoyable meetings that I've been to, and certainly the speakers this morning could just confirming how fascinating the area that we work in is and how much more work there is to do. So what I've always tried to use these sessions for is not particularly to talk about what's gone on in the past and what we're doing at present. It's really to look at the limitations of what we do, look at some promising new approaches, and then add a little bit of speculation, which I'm happy to be talked out of as we go through it. So if I just go to the first slide. So in terms of physiology guidelines, we've done pretty well over the last few years. We've got good esophageal motility guidelines through Chicago 4 and also the BSG technical guidelines. We've got good gastroesophageal reflux guidelines. We've got the Lyon consensus and also, again, the BSG technical guidelines. In terms of hydrogen and methane breath testing, we've now got a BSG consensus on how to perform and interpret hydrogen methane breath testing, which is a big advance that's happened in the last year, although it still remains a fairly controversial area, especially within a group of gastroenterologists. So the question today is what's missing? I think what the first talks have shown is in the standard patients that are fairly uncomplicated, we've got very good ways of identifying them and treating them effectively. But it's that 30% that are the challenge, and then within that 30%, all the other subgroups that cause us sleepless nights and many different issues. So, to my mind, what I'm going to talk about today is what's missing. We're going to talk a little bit about SIBO in patients on long-term PPI and some data that we've just published, which hopefully puts that story to bed a little bit. We're going to talk about LPR, gastric motility, antro-pyloric-duodenal motility and function. And I was going to talk a little bit about anti-reflux surgery registry, but Nick has covered that already, so that's great. So this is just, the reason I wanted to present this was that one of the first meetings that we attended over in Marlow was where we were sort of bringing out this idea that hydrogen and methane breath testing could be useful in the assessment of patients referred for anti-reflux surgery. And, I think the data that was shown today about the refractory symptoms and post-operative symptoms, the commonest symptoms are bloating and flatulence. But there's also things like altered bowel habit and other things that persist after surgery that probably were there before surgery as well. So we know from Phil's talk, PPIs increase the risk of gut infections and by definition, therefore, small intestinal bacterial overgrowth. And we also know that bloating, nausea, belching, and regurgitation are the most common refractory symptoms with people on PPI. We know that gas bloat and altered bowel habit are very common post-surgical symptoms. So what we did was a retrospective analysis, and again, this wouldn't have come about without this group, was working with Nick and seeing a sufficient volume of patients to do a retrospective analysis on people who had hydrogen and methane breath testing in patients that were referred for anti-reflux surgery. So there's 104 patients in this cohort. And Jordan, who's joined us today on the call, is one of our recently qualified physiologists who's done a great job in writing this up and getting this published in Surgical Endoscopy, which hopefully will be out. So we took all comers coming through Nick's service here, and what you can see on the graph on the left is that 60% of those patients that were referred for anti-reflux surgery had an abnormal hydrogen and methane breath test result as delineated by both the BSG and the North American guidelines. And that abnormality is either SIBO with increased hydrogen production, SIBO with both increased hydrogen and what's called EMO, so it's intestinal methane overgrowth or methanogen overgrowth. So these people are producing methane rather than hydrogen, or as well as. And then we also had a group of patients, a smaller group that just had methane production. So methane production is associated with slowing of upper gut transit, bloating and belching, but also can cause constipation. So this is quite a fascinating amount of people that, these people have been referred by gastroenterologists, and some of the biggest obstacles I have at a national level with discussions about breath testing and SIBO is that there is a very large proportion of gastroenterologists who don't believe that SIBO is particularly real, common, or caused by long-term PPI use. And they don't suggest that hydrogen and methane breath testing should be used because it's unreliable. And if you do suspect problems, that you should treat these patients empirically with antibiotics. And trying to get papers published in gastro journals on breath testing is incredibly difficult. I don't know what the objection is, and maybe Adam and Andy and a few of the other gastros can enlighten me. But this is why we ended up going to a surgical journal to get this presented. And what you can see here is that in the people with a positive test, you can see increased methane and then an early rise in hydrogen that continues. Whereas in a negative test here, you get a flat line for the first hour, and then when the substrate reaches the colon, you get an increase. This is a normal response. So how does that relate clinically? So if you look at the people with a negative and a positive hydrogen breath test, which were the symptoms that were significantly different? And unsurprisingly, the most common symptoms that were different between a positive and a negative breath test were belching, bloating, and in terms of their pH study with a symptom association probability, there were significant differences in patients with regurgitation and belching. So two of the most persistent symptoms that were refractory to PPI were also more common in people who had positive SIBO tests. And I don't normally do this, but I just wanted to show that we do occasionally get a good review. And this was from one of the American surgeons who reviewed the paper, and just really focusing on how we now think that hydrogen and methane breath testing should be part of the anti-reflux surgery pathway. He basically says that this has been a vexing problem. Many patients have post-operative bloating, and this paper has given him a reason to reconsider the mechanism of that. And so congratulations to Jordan and to Nick and helping us get that published. So I think that will help us to understand the mechanisms of bloating and distension and all these other digestive issues that complicate patients who are coming for anti-reflux surgery. We do a postal breath test now, so post-COVID, we can still look at patients and they can do these tests through virtual appointments if they need them. Okay, so the main part of my talk is really going to talk about LPR and some maybe slightly controversial and unconventional mechanisms of LPR. So I think Jason covered most of this really well, so I won't dwell on it. But there's definitely a group of patients that do respond to anti-reflux surgery with LPR symptoms or stretta, but there's pretty poor evidence on why they get better. And also what we really need to do is try and increase confidence in selecting those patients if we're going to do interventions. Apologies if you can hear my dogs barking. So if we look at the Lyon consensus, the Lyon consensus doesn't really focus on LPR at all. What it focuses on is proving that someone has gastroesophageal reflux. And what you've got here is that people who've got conclusive evidence of reflux, they have an acid exposure greater than 6%. They have an endoscopic diagnosis, so there's not much doubt which is going on. You've got a borderline here where you've got mild esophagitis, and you've got an acid exposure between 4 and 6%, and reflux episodes of between 40 and 80, and these can be mixed, both acid and non-acid. And then as you get further down the confidence levels, you can look at adjunctive or supportive evidence. So you can look at histopathological scores, electron microscopy for looking at dilated interstitial spaces, and something that we're quite intrigued in was low mucosal impedance. So this is something that's measured during a pH and impedance study, which I'll touch on briefly. And then also you've got these associated measures. Do they have a positive reflux symptom association? Do they have increased number of episodes, even though these might be short duration? Do they have a low mean nocturnal baseline impedance? So this is the impedance of the esophageal mucosa when someone is lying down at night asleep. And then something that we're not really going to talk about, but this is a post-swallow peristaltic wave clearance. So how well reflux events are cleared by their motility. And then you've got some HRM measures. Do they have a hypertensive esophageal gastric junction, hiatus hernia, and weak esophageal motility? So these are other things that you can bring into the equation to give you a bit more support if you're going to do an intervention. However, if you're down at this point here and you've got none of this evidence and you've got no evidence of acid reflux, then these are the group that Phil was talking about with functional heartburn. They still might have something wrong, which we're going to talk about now and be a bit more speculative about. So what can we do about LPR? The thing is that you only require very small amounts of reflux of gastric contents to cause symptoms. The throat and the larynx are incredibly sensitive. Obviously, they're trying to protect the lungs from regurgitation of noxious chemicals. And what is abnormal up here in the larynx and pharynx may not well be considered abnormal here. And so the more reflux that comes up into the proximal regions, then obviously the more problem you have, but it might only require small and infrequent events. So one way we can measure this is with a pH impedance catheter. So here you've got a pH sensor and 2 impedance electrodes sitting just above the upper sphincter. And then you've got impedance electrodes down here. And then you've got a distal pH sensor in the distal esophagus. And this is the kind of tracing that we get. So this is conventional. What we've got here is esophageal impedance, and in this patient, the mucosal impedance is very low throughout. You've got the esophageal pH here, and what you can see is an acid reflux event occurring here that's being picked up. This acid reflux event is associated with some of their symptoms of cough. And if we look at the color plot here, what you can see is that you can see the acid reflux coming up. Sorry. The acid reflux, the purple here is the liquid coming up. The pH is dropped in the distal sensor, so this is in the esophagus. And then you can see that liquid is now in the pharynx, and you've got a pH drop in the pharynx. So you've got a correlation there between stomach contents coming up from the esophagus and coming all the way up into the pharynx. But we do have quite a large proportion of patients where you get the pH change in the distal esophagus, but you get absolutely nothing going on in the pharynx. So they may still have symptoms. So the question is, if you do an operation or a procedure to stop this amount of reflux, is it going to have any effect up here in these patients? So I don't think we know that as of yet. And just briefly, Jason talked about inlet patches. This is something that we can look at with physiology. And one of the things that we quite often see with inlet patches is this band of low impedance just below the cricopharynx here. So this is during the manometry. So this is the lower esophageal sphincter here. And this is low impedance in the stomach. And just above here is the upper sphincter. And you get this low band of impedance. That allows us to position the pH probe, as Jason alluded to, at the site of the inlet patch. So this is at the site of the inlet patch here, where you're getting sporadic pH changes that are not picked up in the distal esophagus. So if after Jason's talk you guys pick up more inlet patches, then please put that on your request form and we'll have a good look in terms of impedance, and we can change our paradigm and look at that in a bit more detail for physiology. So if we're not getting all the data we want from the LPR studies that we're doing with pH impedance, then what can we use? And I've put ResTech, don't roll your eyes, because I know that there's been quite a lot of negative press about ResTech over the years. What does it measure? If you can't see it in the esophagus, what are you actually measuring, and all these different things. But with an open mind, we've performed about 20 or 30 ResTech studies now in people who've also had a pH impedance study. And I think the first thing to say is, once it's negative and everything else has been negative, that's really useful, because we can say unequivocally there's nothing going on. And certainly when you see a strongly positive ResTech, and you've also had some pretty good evidence from pH impedance it's positive, then that gives you a good idea it's positive. I think the problem lies with those kind of ambiguous results that lie somewhere in between. But I'm going to try and explain what might be happening in some of those patients. So this is a lady who complains of sore throat and some of those symptoms that you talked about before, of sort of burning tongue and slightly, ambiguous ENT type symptoms, bit of globus, bit of dysphonia. And when we got the ResTech, study back, here you can see you've got the danger zone, as they call it, below 5.5. Then you've got this intermediate zone, and then you've got the non-danger zone above 6.5, where pepsin is predominantly inactive. And we've seen this in a few patients now, where we get these kind of nighttime dips in pH that we don't really quite understand. It doesn't quite go down into this lower level of what they'll call the danger zone. And, speculating physiologically what this means, is it an artifact, or is there something physiologically that could explain why this person is getting these weekly acidic drops at nighttime? And I kind of thought about, fermentation in the oropharynx, because that's the kind of pH range you would get with fermentation. But I had a chat with a gastroenterologist that was actually represented on Marcus's slides of Mark Noah. And what he suggested was that these things can be seen quite often in patients who regurgitate some of their gastric contents at nighttime. So instead of it being pure acid reflux, then this could be weakly acidic stomach contents that have been sat there for a while. And actually, this is a problem predominantly with the stomach rather than with acid reflux per se. So it's a little bit speculative. So we've looked into this a little bit further. And again, this is an unusual, this is her pH impedance trace that she did beforehand. And this is just looking at it within the normal cutoffs of what the software look at. And you can see this is where she went to bed at night, and this is like the first few hours of sleep. And you've got this tiny little change of pH here that didn't really look like much. The software didn't really detect it, didn't really pick it up. And you've got like this little bit here, which is evidence of a bit of gas reflux from the stomach. So, in my usual analysis of a pH, I wouldn't consider that interesting. But when you crank up the parameters, so the impedance here is cut off at 750 ohms. What I did was set the threshold for the software up to 1500 ohms. And what you can see here is that when you've got this little bit of gas coming up here, it was also associated with this liquid regurgitation that sat there. And of course, at nighttime, when people regurgitate, then they don't swallow. There's no gravity to help with clearance. So whatever comes up can sit there for a long time. And even though some of this may have cleared subsequently from the esophagus, if some of this has come up into the pharynx, then is this enough to be causing the kind of irritation that this patient describes? So when we're looking back at this now, then even though on the original pH impedance we wouldn't have seen that as significant, then the question is, are these changes actually physiologically important? Is it a type of reflux that sits below the parameters that are normally detectable? Is there some other phenomena going on? So my focus over the last 6 months has really been looking more at what's happening in the stomach and how the stomach and the pylorus might be contributing to these weird and unusual presentations. So with normal gastric emptying, what you get is you get accommodation of the food that sits in the fundus. You get a tightening of the lower esophageal sphincter, so everything keeps everything intact there. And then you get a slow release of food into the antrum, where it's mixed up by the antrum. The pylorus needs to open to allow some of that out, and you require an intact hiatal complex to keep all of that system pressurized, because if you have a hiatus hernia and you get all this motor activity in the stomach, then what you get is venting of those stomach contents, and that's the postprandial reflux. So gastric emptying can be affected by mainly three things: a weak hiatal complex, so you're getting reflux during this period; poor neural motor function in the stomach; or if you've got a problem with outflow obstruction at the pylorus. So if we just go through some of the causes of gastroparesis, I mean, there are kind of many different reasons why people might have slow gastric emptying. Can be related to diabetes, can be nerve related, muscle related, to pyloric outflow obstruction, can be due to a hiatal defect, which is why gastric emptying often improves after anti-reflux surgery. But there's all sorts of other conditions that might contribute to that. So what we do at the moment is very limited. And I think this is the concept I'm trying to put across here, is that what we do with gastric emptying at the moment is a little bit like we did with water perfused manometry in the past. So what we do is we introduce a meal, and then we measure how well that meal is digested over a 4-hour period. And what you get is a graph here. So this graph will either tell you that it's rapid, it's normal, or in this case, it's borderline delayed. So you've got the T lag and the T half. So if you imagine this is equivalent to the previous sort of peristaltic wave that told you it was either normal, hypertensive, or hypotensive, it told us nothing about function. So what we've introduced in the past 6 months at the Functional Gut Clinic is a technique that will allow us to look at that in a bit more detail about the mechanisms of abnormal gastric emptying. So the question is it behavioral? Do they have rumination? We can check that with manometry, that's fine. Is it medication related? Can you give a prokinetic drug to speed up emptying? Do you need to dilate or Botox the pylorus? Can you perform a hiatal repair to try and prevent reflux? Should this patient be referred for gastric electrical pacing, or in extreme cases, can you perform a gastric bypass? So there's quite a lot of options open to people to deal with this, but at the moment, not very good tools to figure out what the right mechanism is. So we've started to use electrogastrography, which I used to do about 20 years ago, but decided it wasn't particularly informative. But there's been some advances in software and analysis techniques now that make this a little bit easier to interpret. So you put 3 electrodes on the abdominal wall. Okay, and then what you do is take a 10-minute baseline recording of stomach activity. So the 10-minute baseline activity, everyone in the fasting state should have 3 cycles per minute of electrical activity. And this is just the interstitial cells of Cajal, the natural pacemaker. So that tells us whether the person, first of all, has intact neural function in the stomach. And then what we do is a water tolerance test. So the patient drinks as much water as they can within 5 minutes. To see whether they can, first of all, accommodate a normal amount of water, and a normal amount is over about 280 mils. And they drink enough over that 5-minute period to give them a satiety and fullness score of about 7 out of 10 on a visual analog score. So the second measure we get from that is a measure of gastric compliance and whether people can tolerate a normal amount. And then these are the kind of graphs that we get. So at the top here, you've got a normal response, and you can see here at 3 cycles per minute, you've got a normal spike here, and then you get a slight increase over time in the postprandial periods. So you don't get any tachygastria in these patients, and you've got no bradygastria in these patients here. And I'm only really going to talk about one presentation because of time here, and this is in people with a hypernormal response. But what the software allows you to do is to look at bradygastria, and that puts it within normal limits, to look at the 3 cycle per minute, which is in normal limits. That tells you the patient has got normal function, that they don't have any evidence of tachygastria at all, okay? But in this patient here, and this is a patient of Nick's, who his main problem actually was abdominal pain after eating. And what you can see is the 3 cycle per minute wave is here, but it becomes a hyper response after the water meal, so it just keeps getting stronger and stronger and stronger. Now, this profile is associated with pyloric outflow obstruction, and I think this is akin to what you see with high-resolution manometry in terms of outflow obstruction from the esophagus, where you get increased peristaltic vigor. And you can see here in these 2 time points here that the 3 cycles per minute go above the normal range during that period. And data coming out of the States, which I'm going to show you now, splits out the EGG activity into 3 different domains. So if you start with hypo motor activity, so this is less activity of 3 cycles per minute. This is what you see mainly in diabetic neuropathy, and we've seen good examples of this in the cohort we've studied so far. These are difficult to treat patients. They don't really respond very well to medication. They may require gastric pacing, and you just have to manage those symptoms. So these are very much akin to what you see in people with absent esophageal motility in many ways. Then you've got the people at the top here with hyper gastromyoelectrical activity, and this is mainly due to antro-pyloric-duodenal dysfunction and predominantly outflow obstruction at the pylorus. And according to the studies from America, then pyloric therapy, either with Botox or with dilatation of the pylorus, has very good outcomes in this group of patients. I think Nick is yet to be brave enough to do the pyloric therapy on the patients we've identified, but we'll ask him. And then you've got the people who've got normal gastromyoelectric activity, no obstruction. And in those patients, that correcting the hiatal defect improves those symptoms and the gastric emptying in up to 85% of people. So the problem is reflux as opposed to an outflow obstruction. But then you've also got those tricky patients that sometimes have increased tachygastry as well. And they have a nausea predominant symptom, and they seem to respond better to things like prokinetic therapy. So we're still at the very beginning of trying to understand how useful EGG in combination with all the other things we do is going to be. But, we like to be at the forefront of these things. The data looks promising. In particular, a lot of this data was gathered for people having stretta, where the problem seems to be in stretta that if you've got some outflow obstruction in the stomach as well, and those patients do a lot worse. So it's thinking a little bit further downstream with our anti-reflux procedures that actually the problem might not always just be at the hiatal complex, that actually if there's a problem in the stomach and how the stomach's emptying, then that can contribute, and normalizing that in conjunction with the anti-reflux therapy could improve outcomes in these patients. So that's the kind of speculation bit. So just kind of finishing off, I think what we've always got to think about with this group is whether we're followers or leaders. It's quite easy for us to follow the guidelines that have been put out there. But I think, we are doing things, we're at the forefront of things that are going forward, and we're in a position to actually put our brains together and try and come up with ways to improve things as we go forward. And I think, as Nick touched on, what would be quite nice when we have the discussion at the end of this is try to look at how we can set the agenda in these controversial areas and these difficult to explain patients, and collaborate for the next 12 months on trying to gather data and make some differences. Otherwise, we won't make a great deal of difference. So thank you very much, and happy to answer your questions.
So, Anthony, thank you very much. Fascinating as always. You are undoubtedly at the cutting edge in terms of GI physiology. To answer your question, I haven't actually treated the two patients that we've got in line at the moment. I think they're just in the pipeline. And what we're planning to do with those patients is to do Botox injections into their pylorus and then assess their response, because I'm just a little bit wary of doing a dilatation on the basis of the evidence that we got so far. So I can't tell you whether or not these findings were useful or not. We'll see. Perhaps I could just ask you one question, just going back to the study that you talked about in terms of regurgitation in patients awaiting anti-reflux surgery and in whom had positive breath tests. What's your view in terms of bringing in breath testing to the standard workup for these patients?
I think the evidence is definitely there now to support that, and it's quite a simple test. And this is why I kind of asked for maybe some input from Adam and some of the other gastroenterologists of why there is quite a lot of resistance to breath testing from gastro colleagues. I mean, literally, it's been like Brexit when we've been at national level trying to say that this is an issue. That there seems to be gastroenterologists who are happy to refer a patient on long-term PPIs for surgery, but won't refer them from a breath test that might answer the questions, and getting them off the PPI might resolve a lot of their symptoms before they actually need to go to that surgical step. So there's two things. Should these patients be assessed before they're sent for surgery and see if you can wean them off and treat the digestive issue, or should this be a standard practice for surgeons doing this, because the main symptom after surgery is gas bloat and flatulence? So I think there's two questions. Can you do it before they get sent? But once they are sent, if it's not been done, I think that should be a standard part of that workup, especially if they have. It's a bit like dysphagia. If you have dysphagia before surgery, then you're probably going to have it afterwards. So if you've got bloating and flatulence before surgery, it's probably not going to get any better, and it may be caused by these mechanisms.
Okay, so Majid just asked about the cost of EGG and how to choose which patients to do EGG or the gastric emptying study. I think you partly answered that, but you could talk about EGG. And he also asked about positioning of the probe for proximal assessment, for assessment of proximal reflux in the esophagus.
Okay, so as always with these new technologies like we're doing with ResTech, then if people are coming for reflux testing and gastric emptying, then we're doing those EGG and the ResTech things free of charge at the moment while we're trying to assess whether it's useful or not and gather some data. And the ideal would be to sort of have that into some kind of trial at some point. So the cost of EGG is not expensive. It's 3 ECG electrodes. The equipment, is expensive to buy in the first instance. I think it's about 15 or 20 grand, but actually running the test is fairly straightforward. It takes about an hour to do. And the patients that we've selected so far have been those patients that have had sort of atypical symptoms. You've suspected them mainly of maybe some stomach involvement. We've done a gastric emptying study first, and then we've done an EGG. And what we've done so far is we've not really used gastroparesis as a reason to do the EGG. We've done it in people who've had a gastric emptying study. We've also done an EGG just to see whether we can see normal people, we can see neuropathy people, we can see outflow people, and we can see reflux people. And we've actually been able to detect those 4 phenotypes so far, even though we've only done about 15 or 20 patients. So I would say it probably, depending on what we find and what the outcomes of the therapy are, that we would see this becoming a fairly standard thing in addition to gastric emptying.